Good afternoon on behalf of the European Health Forum Gastein, and a warm welcome to our third webinar in a series that we've initiated to keep important discussions going during the pandemic. We called it Gastein Goes Online, Policy Debates During the Pandemic. My name is Doalika Gottlieb, and we're delighted to co-host this webinar with the Nobody Left Outside initiative. It's a collective of civil society organizations who have dedicated their work to improving access to healthcare for marginalized groups. And we have a special connection with this initiative because it is supported by MSD, and it was actually kickstarted in a session in Gastein in 2017. So we're really proud to have facilitated the outset of the important project, and also to see how it has developed over the years. And since then, we've also hosted a session last year in Gastein, and we had a very moving photo exhibition of lived experiences of these communities. We've been working with MSD at the EGFD for a number of years now, and I think part of this successful partnership is that we both agree that we dare to also go beyond the let's say more usual topics, to go more away from mainstream, to work with our audiences in an interactive way, and most importantly, to move away from talking about people to actually hearing stories from communities, from patients, for example. And that has been very powerful over the years. So we're really excited to have such a speaker lineup today, and to have, on the one hand, high-level policymakers, to have NGO representatives, but most importantly, to have also the voice of the marginalized community with us here today. So a big thank you to our speakers for joining us. Thank you for the audience for joining us today. And I'd just like to hand over to Boris Azais, a longtime colleague of ours, who will be guiding us through this session today. Boris is the Director for Public Policy for Europe and Canada at MSD. And yes, over to you, Boris. Thank you.
Thank you, Dorley. Thank you. And thank you for presenting me. I won't have to do it myself. So welcome to the Nobody Left Outside webinar, and thank you for joining us today. Today, we will talk about the challenges faced by marginalized groups in accessing healthcare, and also how the COVID-19 pandemic has amplified these challenges. We will also hear about what actions have been taken or should be taken in order to address this issue. So let me introduce to you briefly the Nobody Left Outside initiative. And you can see on your screen the founding members of the Nobody Left Outside initiative, NLO for short. This is a collective of organizations representing people from some of the most marginalized communities in Europe. This includes people experiencing homelessness, LGTBI people, people who use drugs, prisoners, sex workers, and undocumented migrants. People in these groups are known to be at greater risk of poor health, and at the same time, they face many barriers in accessing healthcare, in addition to discrimination and stigma. So as a result, the people most at need of healthcare are also among the least likely to receive it. And in effect, they are left outside our healthcare system, hence the name of the coalition. As Dorley said, NLO was started in 2017, and since then it has proved to be a unique platform for organizations to speak with a unified voice on the issue of access to healthcare for the communities they represent. And I'm proud that MSD has supported this independent coalition of NGOs from the start. The coalition has been very busy since its launch, and most recently, NLO has developed a briefing paper for the WHO European Office for Investment for Health and Development, a briefing paper aimed at explaining to policymakers the particular challenges and impacts of the COVID-19 pandemic on marginalized groups, and to recommend solutions to help improve government responses. So we will feature in the chat some of the key projects that have been undertaken by NLO. And for additional information and background, I would invite you to visit the nobodyleftoutside.eu website. The webinar, and this webinar is the culmination of the NLO week. Throughout this week, we have launched a series of podcasts, an online photo exhibition, and in general raised awareness on the issue of access to healthcare by marginalized communities. So today we have many voices representing the NLO communities. We have policymakers, we have researchers. Time will be very limited, and I will ask our panelists to remain brief so we can all share during this webinar. I invite the audience also to use the chat and the Q&A tools, which will be monitored and where our panelists have been invited to respond directly to your questions. We will, of course, make sure to bring up some of your questions during our discussion. So with that said, let's start. We have the great pleasure of an intervention by Stella Kyriakides, EU Commissioner for Health and Food Safety.
Ladies and gentlemen, the COVID-19 pandemic is much more than just a health crisis. It has weakened the fabric of our societies, and like any emergency, it has left the most vulnerable, the most exposed. It has been particularly hard for those with fragile mental or physical health, and those whose life circumstances create barriers to accessible health care. Our Charter of Fundamental Rights enshrines that everyone has the right to benefit from medical treatment. But not everyone can practice social distancing, and not everyone has the means to protect themselves with basic hygiene measures. These are the people for whom policies need to work the hardest. Understanding how COVID-19 impacts marginalized groups is so very important. The European Centre for Disease Prevention and Control has prepared guidance for member states on support for medically and socially vulnerable populations, underlining the essential support services provided by many NGOs. At the same time, the Commission has called on member states to protect vulnerable groups in their short-term preparedness plans, and we continue to discuss specific measures in the Health Security Committee to ensure better preparedness in the future. Unfortunately, while many people are considerably tired and understandably tired of COVID-19, the pandemic is not tired of us. We have always maintained that none of us are safe until everyone is safe. That applies also for those who are often out of the public eye. As we continue to face this crisis, it is important that we listen to our public health authorities, implement the advice, and avoid unnecessary risk. Because we are not just protecting ourselves, but also those who may not be so lucky to retreat into a safe space at home, away from community transmission of the virus. Looking ahead, we need to reflect on the lessons learned, and we need to ensure that nobody is left outside or behind. The pandemic has highlighted the inequalities in our current health systems and the challenges faced by marginalized communities. But it must also be an occasion to build back better for everyone. Universally accessible and affordable healthcare remains a key priority for this Commission. This is a basic human right, and there is no place for discrimination. There will be a time after the pandemic, but until then, everyone must be given the best chance to protect themselves from COVID-19 with clear and accessible information, with accessible testing facilities taken to vulnerable groups if necessary, and with fair and equal treatment based on clinical and objective criteria. I'm very grateful to the Nobody Left Outside initiative for bringing the voice of marginalized groups to the table. And I wish you every success with your conference.
Well, this is great, and I will extend on behalf of the NLO Coalition many thanks to Commissioner Kyriakides for having shared these important words with us. I will now call on our first panel to join us on the screen. While you're turning your camera on and unmuting yourself, we have Lucas Stevenson from the International Committee on the Rights of Sex Workers in Europe, Keenan Russell from ILGA Europe, Roberto Perez Gallo from Correlation, European Harm Reduction Network, Rosaline Mbayo, European AIDS Treatment Group, and Denis Onyango from the Africa Advocacy Foundation. So thank you for joining us today. You've been founding members of the Nobody Left Outside initiative. And to start, I would ask each of you to tell us more about the access to health challenges faced by the communities you represent and what should be done to make health services more accessible. So in no particular order, I'll start with you, Luca.
Okay. Hello, everyone, and thank you very much for having us. I represent a network of 100 organizations working with sex workers or led by sex workers. And by sex worker, we mean anyone who working in the sex industry, but of course, in majority people in prostitution, etc. And some of the main obstacles to access to healthcare is both the stigmatization and the criminalization of sex work. We know that many people are involved in prostitution across Europe for many reasons, because it's their choice, because of lack of choice, because they are undocumented migrants, and that's one of the rare economic opportunity for them. And often they are not able to access simple services because they will be unfairly treated by the service provider. And often sex workers also share intersection of oppression. They might be trans sex workers, as I mentioned, undocumented sex workers, Roma sex worker facing homelessness, and all these different forms of oppression really make obstacles for sex workers to access health services.
Great, thank you. So turning to you, Keenan, can you share about the work of ILGA and your own views on access to healthcare for your community?
Absolutely. Firstly, thanks very much, Boris and hello, and Gastein for making the space for us to have this conversation today. My name, as they say, is Keenan Russell. I'm the Senior Policy Officer at the European region of the International Lesbian, Gay, Bisexual, Trans, and Intersex Association. We are based in Brussels and represent more than 600 member organizations across 54 countries using the WHO's definition of Europe rather than the EU definition. When speaking about LGBTI people, the exposure to stigma, discrimination, and violence in healthcare settings is a real and manifest thing. Published this summer was the FRA LGBTI survey, the second one that they've done on LGBT people. And in that survey, they found that 16% of LGBTI people generally had been exposed to discrimination in the healthcare setting in the past year, which jumps to 34 or 35% when talking about trans and intersex people specifically. So more than 1 in 3 trans people and more than 1 in 3 intersex people were exposed to discrimination and or stigma or harassment in healthcare settings in the last 12 months. Another way to frame that particular piece of data is they also asked about or collected where discrimination takes place. And again, among LGBTI people who had experienced discrimination in the last year, 15% of that discrimination took place in healthcare settings compared to employment and school and all of the other settings that happen in life. So this is certainly one piece, it's a reality. But the other piece is also that the political environment that we live and work in is one where there is an attempt by certain actors in our society to allow for that discrimination, to legislate that discrimination should be legal and allowable. And it's absolutely vital that we hold those forces at bay and clarify that access to health can't ever be based on discriminatory measures, regardless of, for example, whether someone believes that a person's sexual orientation or gender identity is appropriate or not. That's not a valid basis to deny them access to care.
Great, thank you. So again, and sorry if it seems like speed dating here, but we really wanted to feature all the voices from NLO. So Rosaline, if you can step up and share with us.
Yeah, I'm also grateful and thankful for being here. I'm representing the EATG, the European AIDS Treatment Group. I mean, have membership all over Europe, and representing Germany and the African migrant communities. A minority, I mean, in Germany and in Europe, most European countries, but they are faced with many challenges with language barriers, resident permit issues, socio-economical problems, cultural and religious barriers, limited knowledge, I mean, just to name a few. And most of them don't have access. I mean, we can divide them into two groups. You have those that are asylum seekers or refugees. I mean, they have limited access because of the asylum seekers laws. And then you have the undocumented, I mean, migrants that don't have any access depending on the country they live in. I mean, in England, African migrants have some access even if they are undocumented, but in Germany, they don't have any, rights to health care. And this has been a very, very big problem. And most of the times, we have to do advocacy and try to see how to lobby for these people to get into the healthcare system, especially in Germany, where you have structural and institutional discrimination. I mean, that means that for you to have access, it depends on your legal status. I mean, if you don't have the right status, you don't have access at all. And even those that have access are so discriminated against that it's a big problem.
All right. So talking about migrants, maybe I turn to you, Dennis, to tell us about your activities.
Yeah, thank you for having me, Boris, and thanks for this forum. I work with Africa Advocacy Foundation, which is an organization working with migrant communities in the UK and across Europe. And, we know for a fact that there's evidence of persistent inequalities between people who are originally European, citizens or nationals, or people who are born in Europe and people who are coming into Europe as migrants. And so we see this evidence of unmet needs in sexual and reproductive health services, in dental health services, and also mental and maternal health in most cases. And I think the single biggest factor really is the legal and regulatory barriers that keep people from accessing services. We know that health is a human right. We also know that, it makes economic sense to treat people, early, or to catch, people when they're still not really at the point of crisis. And so, we also know that a lot of migrants come into Europe when they are very healthy, but the conditions that they're exposed to is what actually makes their health worse. And so we've seen for over the past few years a lot of negativity, hate, xenophobia, and really very, very bad public attitudes towards migrants. And this has a serious effect. Now what we see with the communities we work with is that, health is not a priority. It's more about survival. And so, when you do not address some of the social determinants, when you don't address poverty, when you don't address, homelessness, and you don't address issues to do with, people's, well-being in terms of social protection, the health will get worse. So we feel that the single biggest problem really is the legal and regulatory issues. We know that, in theory, there are around 4 or 5 countries that provide universal access. And I think that includes Germany, England, Portugal, probably, and I think probably Belgium. But in practice, the barriers are there, the structural barriers are there. So I think that is something that we really need to address. And as Rosalind has said, she's highlighted a lot of other issues, which I will not go repeat. But for me, that's really something that needs to be looked at.
Yes, indeed, and it seems that there is a lot of intersectionality among the different communities, and that was also one of the aims of the Nobody Left Outside coalition, because when we first met and started this initiative, I think one key factor of the success was that there was a realization of all the the commonality across these different groups, in particular when it comes to accessing healthcare. So Roberto, you're from Correlation, an organization that we have been working with for a number of years. And can you tell us more about the challenges for people who use drugs and also your work as harm reduction?
Yeah, thank you for inviting today. Indeed, I'm working for Correlation, the European Harm Reduction Network, which is a CBT organization that is like working also in WHO Europe. And then we are operating at the moment with more than 170 organizations, harm reduction organizations, policymakers, that they are working also like on the field trying to support people who use drugs. I have to agree with has been presented already, because actually for us, one of the things that is still being one of the challenges is the social determinants of health, particularly when it's coming to criminalization, stigma, and discrimination. Particularly still in many places in Europe, we are facing the drug use and drug possession is actually one of like the biggest barriers to access health and social support. And this generates not only like a lack of trust in services and authorities because of the negative experience of fears, because actually it's like drug use is tackled through a law enforcement perspective, but also it's like hampering all take of information and all take of access like of the possibilities that exist. And another of the things that we are seeing that particularly for these groups we are working with and for that they do not have any other access point than harm reduction services, ensuring the sustainability and the support to harm reduction is becoming incredibly crucial. Because, for example, we are seeing in many areas, particularly in Eastern Europe, that harm reduction services are struggling to be able to do like just contact or to be able to survive. Or also, like even harm reduction services are having difficulties to be incorporated as a fundamental part of health and social support systems. And this is like completely, important when suddenly we are looking at drug use is not a phenomenon that belongs to a very particular kind of like community, but drug use is intersecting with sex work, drug use is intersecting with migration, is intersecting with homelessness. So all of these factors start to be compounded.
Yes, I'm conscious of the time, and I really wanted to hear from you very quickly also what has been the impact of the COVID-19 pandemic and whether you feel that this has been addressed properly by governments, or if you have some key actions to recommend. And let's use the same order. Please, Luca.
So as you can imagine, COVID-19 has been extremely negative for sex workers, in particular the most precarious sex workers. Basically, as soon as the COVID crisis started, sex workers lost all their income. But because the majority of sex workers are not recognized by workers, by the state, they were not included in any economic or social measures. And they were basically left to fend for themselves. And without the work of a really grassroots organization, many sex workers were at really high risk of like homelessness or not able to even feed themselves or their children. Keeping in mind that a large number of sex workers are mother and single mother who do sex work in order to provide for their children, not only. And that's been really, really negative. What we've seen is that organizations have stepped up and have managed to raise some funds and provide services to sex workers during the crisis. What we have seen as well is a huge wave of mental health issues, including a large number of suicides in the community. We had a trans sex worker setting herself on fire in Georgia to protest against the exclusion from the government. So it's been really, really dramatic. I'm not trying to limit here, like it was really, and it's continued to be. And what is really frightening is that not only governments are not including sex workers in their responses, but many governments are now trying to increase the criminalization of sex work. We see that in Spain, there is a debate on shutting down the brothels now that during the COVID crisis. In Scotland, there was a new consultation to criminalize clients of sex workers. And in Brussels recently, the city of Brussels just forbid prostitution fully because of COVID. And this is actually not backed by any scientific evidence. You know, the World Health Organization, UNAIDS, all academic evidence point that decriminalization of sex work is the best answer to ensure that sex workers have access to basic rights, including the right to access to healthcare. So what is really scary is that as we're entering a second wave, and many countries have already entered a second wave, sex workers are even more precarious than they were in the first place, are still not included in any governmental responses, and now as well are facing an added wave of criminalization. So it's extremely worrying for us.
Okay. And Keenan, maybe if you can say a few words about the impact of the COVID-19 pandemic.
Yeah, first, I'd kind of like to jump off of what Luca laid the groundwork for with respect to commenting on organizations sort of picking up the slack for gaps in government services to vulnerable groups. You know, this certainly happened. It happened extensively in the region among LGBTI organizations. I'm sharing right now in the chat a link to our resources, which includes an impact monitoring report where we collected examples of countries where they're stepping into that support, a direct support services role. While that does seem like a win on one level, it actually, in our opinion, is a very negative thing that organizations that are primarily designed to work on advocacy and policy work are having to reframe their entire organization, their entire budget, their entire means of operation to address this direct service issue. They were able to do that, and many of our community were able to survive thanks to those resources, but that's not the way that this should work. And it's particularly worrying in a context with dramatically heightened polarization, the rise in populism and far-right efforts to deny the human rights of LGBTI people, to see organizations that were doing critical human rights-focused work now having to shift their entire process to essentially keep the community alive. And these radical far-right forces are still at work making policy change that will impact our lives, not just today, but moving forward, with Hungary being a fantastic example of that, seeing legal gender recognition become essentially legally impossible in the Hungarian context during the crisis. So there's a need to think about how the movements are funded and supported so that that critical policy work focused on broader human rights frameworks is able to continue, and we can keep our communities alive, housed, fed, and have their basic needs met during crisis.
Great,
Yeah.
great. Go ahead, Rosaline.
Yeah,
we may have to take some questions from the audience as well. So let's be very brief.
There were a lot of issues, as mental health issues, as Luca already mentioned. Access to medication was limited, and the persons without insurance, they were completely left out. There were also ethical issues, of problems sharing data, on telephones and WhatsApp, and the area of social distancing was not being kept in asylum homes. People felt imprisoned, and also people have to go digital, and that was a big problem for those that did not know the language, couldn't read or write. They lacked the resources, the technical skills, and also they lacked the equipment. There was no internet, so it was very, very difficult for people to get access. And nevertheless, the organizations, the community organizations, or community-based organizations were able to give helping hand to support their people.
So, Dennis, tell me, Dennis and Roberto, if you have something really important to share, which I'm sure we also have questions. So you tell me, or either your brief and we take your thing.
I think across Europe, what COVID has done is to highlight the inequalities that are there among populations that are not served well with health, by health and healthcare systems. We've seen in Greece right now, after the Moria fire, the camp fire, that over 12,000 people have been left without accommodation. But also coming back to, like in England, we know that a lot of people have been bereaved. So that's something that has not even been taken care of in terms of the healthcare system. And without mentioning, a lot of issues that Rosalind and Siren has already mentioned. I think that, we have seen that a lot of people, the destitution has increased. And I think that COVID has taught us one thing, that we need to look after people. We know that when governments mean to do something, they can do it. And I think that, the fact that migrants are persistently left out in some of these measures is quite shameful. A lot of charities have come up and have been innovative. A lot of private foundations have funded initiatives. And I think that what disappoints me is that a lot of governments across Europe are still not even extending that support to people who are most vulnerable. So that's my comment on that.
And Roberto, in terms of harm reduction, what has been the impact of COVID-19 and the lockdowns and so forth?
Yeah, there has been already like many things mentioned, because as we have seen, like many of the communities we work with and for actually are completely intersecting. But in the concrete case of like drug use, we have seen a decline in the availability of like drug services in general. This could be from community-based hepatitis, viral hepatitis, HIV, or sexually transmitted testing and treatment has been completely removed or inaccessible in many places. We have seen that opioid substitute treatment in some places has been also like completely altered. Needle exchange programs also like has been happening and completely, and also like the relationship is having also with transmissible disease. We have seen also like homeless and shelter services completely removed. And within all of these, also like as it was like mentioned, has been like the civil society, particularly users groups, community-based organizations that has been completely instrumental in delivering services, particularly through outreach services. And sometimes has been like the very basic facts actually has been needed to be provided, from food, from water, from actually places in which people can be, just even before tackling anything else. For us, I guess it's like what we are finding some elements that they are like kind of like crucial is like, for the first time on a municipal level, we have been seeing like an increased coordination of the services and certain attempts to do some integrated approaches. And this is something that we want to encourage and continue doing. And this particularly speaks a lot about all of the contingency plans. Actually, they should be incorporating the communities we are working with and for in the design of the elements, because oftentimes we have seen that many that the COVID-19 prevention measures, like staying home, physical distance, or certain elements are not really realistic with the situation that actually our communities are living with. Also, it's super important we are seeing that certain coercive measures should be suspended, like enforcement of confining measures by police. The violence that actually many of the communities we work with has been experiencing in public space should be completely tackled, or like non-violent offenses. All of this, actually the role of the police and law enforcement should be also like reconsidered. And then, yeah, there's like actually quite a lot.
Thanks. No, this is really important. And Roberto, please, as well use the chat because we're coming to the end of our panel here. Let's hear it from Dorothea if we have questions or.
Yeah. Hi, thank you. There are a couple of very interesting questions, and there are two I would actually like to put forward to the panel. So one is on a matter of communication and health literacy. So a question is what can public health agencies do to ensure appropriate, understandable, and accessible information that reaches everybody in the communities? And another question that also is very interesting is what are the effects on children and young people in the communities that you represent?
Okay, so who wants to go first? I don't need to necessarily decide. I think those are two very different questions. Just maybe address one very briefly.
I can take the one for young people and children. So especially for vulnerable families, we have seen that a lot of kids, so for example, if you look at education, the onset of transition to digital services affected a lot of families in poverty. So you find that our kids could not do homework. And so obviously charities that are supporting had to mobilize to ensure that we have equipment and connectivity to ensure that the young people are able to engage in learning. But also, if you look at other factors like domestic violence, there's evidence of increased domestic violence in families. And so a lot of these kids have obviously, because of the lockdown and because of the restrictions, have been witnesses to some of these challenges around violence. And so we have also tried to address that by using our normal sort of interventions around working with families and trying to make them safe, especially for the vulnerable women. And generally, I think it's more about how much you're connected to the community. So for a lot of families that we support, there is always that peer support aspect and the community connections. And when that is cut because of obviously the concerns around health, then you have got to innovate and find a way how you can maintain that contact, either through phones, either through regular conversations, but also ensuring that those ones who are not safe or are really supported to access justice.
So Rosalind, you wanted
Yes,
to?
I want to talk on the health literacy. The participation of the migrant community themselves plays a very key role in developing materials and also looking at the communication methods. What are the best methods? Is it going to be print media, or is it going to be like videos, and whatever has to be done? That's the community must and should be part of everything that is being done, from the conception to implementation and also the evaluation.
Thank you. Roberto or Keenan, yes, because on this issue of communication, maybe you want to address it.
Yeah, I'd like to follow up on what Rosaline was saying very briefly, just to say that there's a need to tackle the structural discrimination and stigma within healthcare settings at the same time as attempting to build literacy. You can't do one without the other. And so when, as Rosaline was suggesting, it's vital that communities are involved in developing work on literacy, but they're only going to be involved honestly and thoroughly when they feel safe in the space and safe enough to be able to say, these are what my barriers look like, and know that those barriers will be addressed. So in the context of healthcare settings where people are experiencing direct individual discrimination every time they come to that setting to seek services, you have to be dealing with that to be able to work on anything else, or you can't do one without the other.
Great. So Luca, you have the last word.
Okay, perfect. Well, it was to follow up on what Keenan and Rosalind was saying. For sex workers and many marginalized community empowerment is really crucial to reaching out these communities. Often we are called hard to reach, but sex workers and other groups are not hard to reach. Clients can find us, the police can find sex workers quite easily. The reason why sex workers don't reach the services is because they are discriminated from it. And there is a lot of resources, including by the World Health Organization, on community empowerment and how to develop this so that sex workers are empowered and feel that they can trust the authorities, including health officials. Thank you.
All right, thank you. Thank you very much all for having shared with us today the experience and the challenges and what your organizations are really busy working on. So I invite you to continue to interact in the chat and address questions that might be raised in the Q&A. Thank you very much. And
thank you.
Thanks very much.
Thank you.
So now we'll move to Dr. Hans Kluge, Regional Director for the World Health Organization Office for Europe. Hello, Dr. Kluge.
Hello, Boris. How are you? So nice to see you. And I really enjoyed the panel. I mean, great panel. I'm very, very honored to be part of it.
Yes, thank you very much. Thank you for joining us. This is great. We have shared a few panels, both of us, and it was again thanks to the European Health Forum Gastein. So not to spend too much time, I just wanted to ask you what is the work and the recommendations from your organization on addressing social determinants of health and the interplay with the COVID-19 pandemic and related actions for our health systems.
Thank you, Boris, and thank you to the European Health Forum of Gastein, the president, Dr. Clemens Aurer, and Dorley and the team to be part again. So we prepared our position, Boris, which is a little bit more formal, but then I can assure you that any questions that colleagues, spectators would like to pose, I will try my level best to answer those. So as I was telling, it's really a great opportunity to speak to all of you today, and congratulations to all the panel members. WHO was also mentioned a number of times, and I can only endorse what you told. This forum here is very timely because we all grapple with a surge in COVID-19 cases across our region. And at this juncture, with a more sophisticated understanding of the virus, our responses must reduce what I call the collateral damage by the COVID by targeting the individual needs of all members of the population. So in addition to our understanding of how the virus spreads, the last 8 months have taught us that the pandemic's impact has been terribly unequal. In fact, for me, this is the biggest lesson learned, that COVID-19, in fact, exacerbated the inequalities. Vulnerable groups and marginalized communities continue to be disproportionately affected, both in terms of public health and through the social and economic disruption. When the COVID-19 arrived in our region and the countries began to respond, programs and services that had been designed to help address the needs of the marginalized groups quickly stalled. And that's what I also heard from the panel. Children living with disabilities were further disadvantaged by school closure and inadequate distance learning measures to meet their needs. And when resources were rerouted to assist with the COVID-19 response, life-saving community services were heavily disrupted. The closure of community sexual health services increased health risks for sex workers, for people who inject drugs, opioid substitution therapy, and the provision of safe needles and syringes were halted due to the lockdown, self-isolation, and reduced pharmacy services. As the nations locked down, those living in precarious situations were pushed further to the edge, and people experiencing homelessness were caught in an impossible scenario. Their cities were closed while there were few safe spaces to go and little opportunity to physically distance. For people living in violent or abusive home environments, they were confined with their abusers. Precaution measures that were mandated by governments were impossible for some marginalized groups to adhere to. Migrants and refugees, particularly those living in camps or those in transit, had few health services they could access, and testing was just impossible. People in prisons and other places of detention were stuck in conditions to facilitate transmission of disease. And Roma and traveler communities were confronted with limited access to sanitary necessities, such as clean water, make it impossible to implement precaution measures. All these conditions are unacceptable and will have a public health impact that far outlives the current pandemic. Understanding the additional challenges of COVID-19, we must scale up our action. The 5 essential conditions for healthy living provides the scope of things that need to be addressed. For me, social justice has been the foundation of my entire public health work since I began to work as a family doctor in Belgium many years ago. When I became regional director, prioritizing the needs of marginalized groups was central to my mandate and has been operationalized in our Vision for Health 2020 till 2025, the European Programme of Work adopted by all 53 countries mid-September. And the EPW will address the varied needs of marginalized groups through 3 spheres of work. 1, innovate. Creative approaches strengthening access to health services. 2nd, recreate. Build back resilient health systems. And 3rd, advocate. Prioritize health for all in the public policy arena. And I'm doing this, walking the talk, whenever I am meeting ministers of health and prime ministers. First, capitalizing on new frontiers in health to reach marginalized communities. For marginalized communities, access to adequate care was diminished, as I heard. And for healthcare to be effective, for truly everyone, we need to reach people where they are. Great initiatives are run across the region, where communities and peers are engaged and specialized organizations are on the ground. For example, in Bulgaria, when COVID-19 caused clinics to close, the Single Step Foundation trialed sending free at-home HIV testing kits to vulnerable population groups to help them know their status and then seek the relevant care. I myself, in the midst of the COVID-19 pandemic, I went to Turkey, to the border with Syria, to Gaziantep to overlook the medical convoys and I visited primary healthcare clinics where I saw really people-centered health services. The Turkish people had trained, retrained, recertified nurses, psychiatrists, doctors among the Syrian refugees, and they got salaried in the primary healthcare in Turkey to deliver cultural sensitive, gender sensitive services. And these types of programs require ongoing investment that can be increased during health emergencies. Alternative service delivery platforms, the new frontier of digital and remote services, should be scaled up to reduce barriers and help provide cultural and language appropriate information. Second, building resilient health systems that leave no one behind, that leave nobody outside. The pandemic has forced our health systems to adjust with unprecedented speed. A shift in the provision of health services, particularly those at the community level, must be done with an in-depth understanding of what it actually means. And as the pandemic continues, health services must operate what I call a dual track on the COVID, but also maintaining the existing health and social care. Marginalized groups need adequate resourcing, human and capital, and stronger referral mechanisms. We must triple down on responding to persistent challenges that have been exacerbated by the crisis, including investment in mental health care. I launched, immediately after the approval of the EPW, the Mental Health Coalition under the auspices of the Queen of Belgium, Queen Mathilde, who is the SDG advocate for mental health. In Madrid, for example, in Madrid in Spain, when more than 60% of mental health beds were converted to care for people for COVID-19, people with severe conditions were moved to private clinics to ensure continuity of care. Essential services were set up to enable mental health care workers to continue outpatient services over the phone, and home visits were organized for the most serious cases. So it's possible. Paramount to the provision of adequate sharing are ongoing efforts to fight stigma and discrimination that contributed to poor health outcomes of marginalized groups. The resource allocation should be based on the need and guided by equity frameworks our office developed. And finally, third, health central on the political agenda. 8 months into the pandemic, there is a new awareness of the importance of social and health services for social cohesion and economic development. And we should capitalize on this, including to strengthen access and policies, to fight policies that exacerbate stigma and discrimination. What we need is integration, a cross-sectoral approach, not in theory, but in practice for structural change, to elevate health and social care as a societal and political priority. In Germany, for example, the government has consulted philosophers, historians, theologians, and behavioral and social scientists, which provide valuable input on the educational progress of children from disadvantaged families. So much we can learn from this approach. Overall, our European program of work helps to serve this purpose through a combined commitment to leaving nobody outside and building the capacity of health officials in our member states. Our political engagement through the EPW promotes health on the political agenda to drive progress towards an economy of well-being with people in the center. And we are continuing to explore a range of mechanisms, ones that bring together sectors and technical expertise to help us move outside the biomedical sphere with a greater emphasis on citizen engagement to tackle the persistent inequalities in marginalized communities. As part of this work, I have set up the Pan-European Commission on Health and Sustainable Development, chaired by Professor Mario Monti, which brings together high-level commissioners from a range of fields. The Commission is looking forward, through the impact of the pandemic, to elevate health to the top of the political agenda by offering guidance how to invest in health and social care systems for the benefit of everyone. despite the immediate public health needs driven by COVID-19, we must have a view to the long term. Efforts to maintain health high on the political agenda should also include advocacy for action to address common causes of vulnerability, such as safe and fair working conditions, the legalization of migrants, and, as one respected friend was telling, decriminalization of sex work. Throughout this pandemic, I have frequently said that no one is safe until everyone is safe. And this is a reminder to every member of our collective response, from policymakers to health workers to community members, that if we want a way through the crisis, we are required to bring everyone along. If we want to protect ourselves from future crises, we will leave nobody outside. Thank you so much, my friends.
Well, thank you very much, Dr. Kluge. This is great, and actually, we were receiving questions during your intervention, which you almost all covered quite well. And I'm quite happy to hear that the crisis has not been lost as an opportunity to improve health service delivery and design. Actually, we've seen a tremendous increase in the investment in healthcare and a live, though unfortunate, demonstration of the value of health as a key driver and of economic growth and well-being in our society. So this is great. So I would just ask as a follow-up question that what two things. First, a very practical one. What would you tell the Nobody Left Outside members on how to increase our interaction with your office and the WHO Europe regional office, and also more fundamentally, what can your organization do in order to counter the inequalities and stigma in access to healthcare during the COVID-19 pandemic?
Thank you, Boris. I mean, really key question. So the first one, how to interact, straightforward. If there is a delegation, we could set up a video conference. We also have an office in Brussels with Ambassador Oksana Dementi, who's in charge. So we can link Oksana in. And here I invite whole my team, because I want to walk the talk on intersectorality. So I have a great new director team. And as I was telling, as many of you know, social justice has been the foundation of my entire career. I started as a family doctor. Then I moved to Médecins Sans Frontières, establishing tuberculosis control programs in the war zone in Kismayo in Somalia, in Liberia, 2 years in the prisons in Siberia, worked in Myanmar, North Korea, and I have seen the power of the communities and the power of partnership. So absolutely, please come on board. And I give, let's say, very concrete suggestion. We will have 3 more meetings of the Monti Commission. I will be more than welcoming to have a representative, because whatever we come out with that report has to take into account the needs of the more vulnerable population. So this is the first very concrete invitation to follow up with Oksana and me. Second is a very big one on stigma and discrimination. In fact, I was very, I say impressed, but impressed a little bit in not so much in the positive way, when one of the respected panel members was telling about, I think one third of the discrimination experiences in the healthcare services. So this is very worrying. This is, and I'm aware of this. So this is not new, but the percentage is a bit new for me. From my side, as I was mentioning, I am meeting on a daily basis presidents, prime ministers, ministers of health. Yesterday, great discussion with Minister Vasilis Kyriakides from Greece, who was here in Copenhagen in the office, and we speak about Lesbos, about our operation on the migrants. Also there, I'm going to go to Ukraine in November, and there definitely I will meet the Minister of Justice on the prisons, because I know the colleagues very well there. On 3 weeks ago, I was in the Russian Federation with my first official visit at the highest possible level, Prime Minister, Minister of Foreign Affairs, and Minister of Health. We decided, I asked Excellency Minister of Health to co-chair next time the high-level working group on HIV/AIDS together. The minister who I know very well, myself. So that's at a political level, but it needs to trickle down. So the policies are there, as you know, Boris and friends. It's more on the question of the how. How do we implement? I think first and foremost, we need to walk the talk. People are looking to us, to the health leaders, and we how we behave, how we appreciate, how we speak. You know, this has to be part and parcel of our normal speech. It shouldn't be anymore that basically, right, we have the symposiums specifically on this group. The dream is that this is mainstreamed into the society. But of course, we still have a long way to go. Maybe a last example, I mentioned the Mental Health Coalition, and that will be a coalition of highest level political leaders, including heads of state, same time people affected with mental health, scientists, etc., under the auspices of Queen Mathilde to really advocate for decreasing stigma and discrimination. And I have seen in my own experience as a medical doctor that when healthcare workers are speaking about stigma and discrimination, this is very powerful. So not necessarily the regional director only, but first and foremost, the healthcare workers, right? Let them speak and share positive experiences and engage the communities in our policy making. And there I think we have made a lot of experience, especially in HIV and TB control, that we used to involve the communities when to implement policy. Now, I must say, even in our own technical advisory groups, the vulnerable communities are sitting at the table already from the design phase. Thank you.
Well, thank you to you, Dr. Kluge. This is fantastic. So we don't want to abuse from your valuable time. We will continue our webinar. We have a great panel coming, so you're most invited to continue to follow our discussion. So I will, just on behalf of the European Health Forum, Gastein, and the NLO Coalition and MSD, I will thank you very much for having joined us today.
My pleasure, Boris. I learned a lot. Thank you to everyone. Thank you.
Thanks. So now I will invite our panelists to join us for the second panel. We are joined by Dr. Julie Gerberding, Executive Vice President and Chief Patient Officer of MSD, Professor Jeff Lazarus from IS Global Barcelona Institute for Global Health, Alina Smith, Advocacy Officer at PICUM, which is short for the Platform for International Cooperation on Undocumented Migrants, and Freek Spinnewijn from FENSA, the European Federation of National Organizations working with the homeless. So great. I mean, we have heard already quite a lot from the NLO community members, from Stella Kyriakides, from Hans Kluge, from WHO Europe. So I will, you know, obviously follow up with some questions to you and really to bring out additional voices and different viewpoints on this issue of access to healthcare for marginalized communities. And if you allow me, Julie, I will start with you. So obviously, as the Chief Patient Officer of a research-based pharmaceutical company, one would think that the primary responsibility and the contract with society of a research-based company is to develop new therapies. At the same time, MSD seems to be quite focused on population health and is looking at a broader level on our engagement with health services and public health in general. So can you talk to us about this?
Well, thank you, Boris, and thanks everyone for participating in this really important topic that often gets left outside. You know, MSD is a company that considers itself in some ways to be a population health company because we tend to focus on large scale population problems that are amenable to vaccines or medicine. So things like diabetes, like vaccine preventable infectious diseases, like cardiovascular disease, et cetera. So that's been part of our core business from our very beginning. But I think we have consistently wanted to go beyond that. And that's part of why I'm so pleased to be the Chief Patient Officer, but why I'm also so impressed with the work that's going on in Europe in this domain. From where I sit, every company, every organization needs to take the long view of how our contributions fit into society and how we can step up to our broader social responsibilities. As an infectious disease doctor, I know that the challenges of this pandemic are just a harbinger of things to come. And we expect, given the broad circumstances in the world, and I'll just mention climate change and the chaos that that creates, the fact that we see people in the urbanizing environments increasingly come in contact with animals, and spillovers from the animal kingdom into the human health kingdom have now become part and parcel of our threat assessment. But in addition, around the world, we have more than 64 forcibly displaced people, either in their own countries or people who've been needed to or required to emigrate for safety purposes or other social issues. And it is that mass movement of people in a context of global connectivity that's really created the situation that we're in. And I don't think that I see any signs that things on that macro scale are going to improve anytime soon. Always in these areas of difficult challenges, the most vulnerable people are the most affected and the most forgotten. And I think if we can help solve the problems of the vulnerable and forgotten people, we will be in great shape for everyone else in society. So the areas of focus here on highly vulnerable people, who are not only vulnerable because of their underlying socioeconomic or health conditions, but also because of the social stigma and sometimes the politics that affect them adversely. It's a privilege to be able to think of how we can help catalyze better solutions that go beyond pills and vaccines, but of course also trying to make sure that the health services that can be provided are provided with good quality in the most equitable way that we can. That's a tall order, but it is a passion. And I think we're looking forward to learning how we can do more and be a better part of the community of people who are working on this. It's a wicked problem and no organization can solve it alone, but by coming together in alliances with governments, with non-government organizations, and with the private sector, I think we have a better chance of really being helpful. So thank you, Boris. I'll stop here.
Thank you, Julie. Thank you very much. I'll turn to Jeff now, because Jeff, you've been a founding member of the Nobody Left Outside initiative, but coming from the public health research dimension. And so as a researcher, I was wondering if you could tell us more about what might be the evidence to make the case for making our healthcare services more accessible for marginalized communities, and if there are any proposals that we can make to health providers or policymakers on how to better design their health system.
Thanks, Boris. And you hear me okay?
Yes.
Great. Well, there's much evidence aside from the importance of including marginalized populations. There's strong evidence that it will be cost saving for any health system in order to reach people earlier, so that when they arrive to the system, they're not arriving late already with an advanced stage of the particular condition. So there are many studies on how to reach marginalized populations of all sorts, and vulnerable populations that we've defined slightly differently here during COVID. That would also include the elderly more generally. The NLO coalition, as you know, took the WHO health systems framework, so taking issues like leadership and governance, funding, service delivery, the health workforce, and so on, and we readapted it with developing a checklist so that governments and health authorities can use that to see how their health system is organized and work together with the community, work together with non-governmental organizations to make those services more fit for purpose. Because as we heard in the first panel, what we're often finding is that populations described as hard to reach really find the system itself hard to reach. They're trying sometimes to get into the system. The communities that represent them are trying to get them access to the system, and the system is putting up these kinds of barriers. So by using this kind of checklist, by working together with the community, we can make the system more effective. It can be cost saving, but then as Dr. Kluge mentioned, public health, our health systems are really about social justice, about empathy, about solidarity, and providing health for everyone and not leaving anyone outside of the system.
Yes, and thanks, Jeff, for mentioning the health service checklist, health service design checklist, because this has been really one of the big and very contributing projects from the Nobody Left Outside. So beyond advocacy, which is really important, there's also this step that these NGOs have designed and proposed a checklist for healthcare providers on how to test the readiness of their health services when it comes to making them more accessible for marginalized populations. And I'm sure that our colleagues are putting the links on the chat or the Q&A to have access to this important document. Turning now to Alina and Freek. With myself. So I was wondering, you're also two founding members of the Nobody Left Outside initiative, and obviously you have a lot of experience when it comes to the challenge of your communities. So how should policymakers address social determinants like housing, migration status to improve healthcare system inclusivity and resilience? And obviously, I will ask the same question that we asked in the first panel about the impact of COVID-19 and whether governments have addressed it adequately. So Alina, please, if you want to start.
Thank you so much, Boris. So maybe just to say that PICUM, we're an international NGO network focused on the rights of undocumented people. We have about 165 members. And Boris, I'm so happy that your question includes the words housing, employment, migration status, and health all in the same sentence. I think COVID-19 has really made it so clear that these dimensions are all inextricably linked. So I want to maybe just say a word to start then about employment and how does the reality for undocumented people in the context of employment bear on their health. And I think maybe one positive thing in the context of a devastating pandemic is that we have more visibility through this pandemic, that many of the people working in what have been called essential sectors or essential services are migrants. And we have entire sectors of our economies that depend on the labor of undocumented people. When we think, for example, about the hospitality sector, when we think about people working in domestic and care work, in agricultural work, in the gig economy. And these are people working in situations of precarity in terms of often precarious work contracts, informal working arrangements, inadequate regulation of their sectors. And so we know that undocumented people already face exploitative conditions and violations of their labor rights, extremely low wages, poor working conditions. And what we see in the context of the pandemic is we add a layer of risk on top of this, linked to health-related concerns. And we also, so we see that on the one hand, we have people who have to continue working and who face additional exposure. And on the other hand, we have people who have had to stop making a living, who've been forced out of their work, who have not been able to continue with their livelihoods. So we see massive destitution without, on the other hand, corresponding access to social protection, income protection, just as we heard from Luca earlier. And so we see that civil society and communities have been mobilizing to try to reach and assist people with their basic needs. But of course, when we have this level of poverty, it has a huge impact on health. It has an impact on people where people can live and how they can live. It has an impact on their nutrition and access to food. And it has an impact on their access to healthcare to the extent that that healthcare is not available for free. So I'll just spend a minute speaking then about how a person's being undocumented affects their ability to access healthcare. And the short answer is it has a significant impact. And in most EU member states, if you're an undocumented person, you have extremely limited access to primary healthcare. And I think it's important to underscore, as we've already heard from Rosaline and from Dennis, this is about structural forms of discrimination and exclusion that mean not only that you can't get services, but you also can't access information about your risk factors, information about how to keep safe. And on the point that we've also heard about mental health, I think all of us know that the pandemic has just amplified mental health concerns. And we need to think especially about young people, about children, about people who already live in situations of extreme precarity and acute stress. And the mere fact of being undocumented, because that is criminalized, creates its own significant mental health burden. And there's no access to mental health supports for undocumented people. So I won't say too much about housing because I know Freek is going to deal with that in depth. So just very briefly, in maybe 30 seconds, to say something about what we would like to see policymakers actually do. I think the first thing is to really go even beyond a response to the public health crisis to address the deficits in our public systems that the crisis has actually made visible. And in that context, we need to seek not only resilient health systems, we need to really strive for resilient societies. And that means really having an approach that is holistic, that addresses access to basic housing, access to healthcare, nutrition, and decent employment. And just in terms of what that means for undocumented people, it means that a person's administrative status has to stop being a barrier to accessing basic services. And it means that, as we heard from Keenan and others, that we need to make people feel safe and secure when they're accessing services. It also means we need to think about the context of people's work, and that all workers, regardless of status, need to be empowered to be able to hold their employers accountable for the conditions of their work. And finally, we need to extend social protection to all people, regardless of status, as, for example, Ireland has done in the context of its pandemic payment, which is open to undocumented people.
Thank you, Alina. So now moving to Freek, and tell us about housing first, and also the challenge of linking services to address the needs of people experiencing homelessness and access to healthcare.
Thank you, Boris, and good afternoon, everybody. And I guess I have to do that in 2 minutes, no? I'll do my best.
I'm afraid so.
Yes. But let me, I don't want to simplify things, but let me first of all say that the Corona crisis has shown that adequate housing is an essential protection against an infectious disease. And housing is probably one of the starkest social determinants of health. And everybody agrees on that. But still, when I look at the lists, the traditional lists of social determinants of health used by public health policymakers, I rarely see housing featuring there. So I think we all agree, but we have to act upon it. Now, for people without housing, like homeless people, the current Corona crisis is extremely difficult. I'm stating the obvious here. Just to put it into perspective about how many people are actually affected here, we estimate that on any given day in the European Union area, there is 700,000, at least 700,000 homeless people, which means people using shelter or sleeping on the street. And that's 70%, 70% more than 10 years ago. So there's something happening at the bottom end of society that we really have to take account of, certainly in times of health crisis as we experience now. Now, it has been stated before, but the public authority guidance to protect people against COVID, such as stay at home, make, of course, no sense for homeless people. You cannot ask homeless people to stay at home. They simply don't have a home. And there is anecdotal evidence of rough sleepers who have been fined by police because they were not respecting the lockdown. That's just impossible. And I heard yesterday President Macron installing a curfew in France. And we know that in France there is every day 3,000 homeless people trying to get a bed in a shelter, and we know that they will not get it. What do these people have to do? We're making the same mistake in the second wave. Now, what it shows to me is that the most vulnerable people are not always taken into account by public health leaders. But it's not only about rough sleeping, it's also about shelter. Shelter is an unsafe place in most countries. It's overcrowded, there's a lot of communal spaces, etc. Therefore, social distancing is impossible. There has been recently a study from Médecins Sans Frontières in the Paris region, which showed, looked at the infection rate in shelters, and they found that on average 50% of the sheltered population was infected. 50%. That's really a cause of concern. And that's why policymakers are frantically looking for other solutions than shelter. Hotel rooms, for instance, or student rooms, or whatever. But I think the actual solution, certainly in the longer term, is housing. You solve homelessness by housing. It's not only a sensible public health measure, it's also a solution to homelessness. And I think we have to use the current momentum around the pandemic to do that. And to quote ex-commissioner Andriukaitis, housing is public health. He's so true about that, and that should be acted upon. So I hope that more of the health resources also at EU level will be spent on housing for very, very vulnerable groups as a sensible public health intervention. Probably a bit more than 2 minutes, but I hope it made sense.
No, thank you, Freek. This is excellent, and I would invite all of us in the audience to also check Freek's Twitter account. And you will find the reference and the link to the study by Médecins Sans Frontières in France, which is quite striking when you look at the huge number of homeless people being affected by COVID, primarily linked to the housing conditions. So I wanted to take this opportunity of having you on the panel of asking you. We've heard Commissioner Kyriakides say this thing, and also Dr. Hans Kluge, about no one is safe until everyone is safe. So what would you say it means if we want to translate that into political action? I know it's a big question, but if you can be brief, that would be great. But I just wanted to give you this opportunity. So maybe we start with you, Freek. So you're not you have an additional 2 minutes.
Okay. Thank you, Boris. Yes, it's of course a big question, but I think we have to make a difference between what is needed now and what is needed in the middle long term. So in terms of urgent measures, one of the things that is absolutely needed is still, you might be surprised, protective equipment for staff and clients of homeless shelters. Just to give you an example, we were offered, France was offered 500,000 masks by a company for free. And we sent an email around to our members to see who needs the masks. And this was yesterday, and this morning, all 500,000 masks was already taken. There is really still, it's unbelievable, but still a huge shortage of masks and other protective equipment in the services for homeless people. That's one. The second thing is guidance. How do you protect homeless people in a pandemic? I would have expected this kind of guidance to already exist, but it is not there. Like, I think it's the role of the ECDC, maybe the World Health Organization Europe, to do that. I know that there is some general guidance for vulnerable people, but you need something specific on homelessness. Like, the homeless sector is really not prepared to deal with COVID in most countries, and we're in the second wave now. Then we need also more safe spaces. Like I said, we have to make sure that shelters are not overcrowded anymore, that people are not forced in the streets. We need more hotel rooms, we need student rooms, maybe some of the Airbnb rooms, like, because they're currently not used because there is no tourism anymore. So that's also something we have to work on. That's of course costly, and maybe some of the Corona money that has been made available by the EU can be used for that. And then testing and vaccines. I was very positively surprised by the vaccine strategy that was published yesterday by the European Union, because I saw homeless people actually indirectly mentioned as a target group. I really hope that the European Commission will use the shelter sector, which represents more than 500,000 beds, to prepare homeless people and help to administer the vaccine. And then very quickly, Boris, on the longer term, it's very simple. We need to change the way we address homelessness. We should not manage homelessness in the shelter system any longer. We have to solve it, and that means providing housing. And this is not impossible. There is one country in Europe that actually is very close to solving homelessness, and that's Finland. They have consistently over the last 15 years offered housing as a solution to homelessness, and it works. And I think in that effort, we have to mobilize the health system as well. I think the health system can also help to move people into homeless people into housing. And I want to finish with one small thing. We have to break the barriers between the health and the social care sector. Can I give you one example? You know, the best predictor of homelessness is the spike in the use of health services by people that are precariously housed. We know that from research, and it's not used at all. So it's just an example to say we have to make sure that the health system and the social care system work better together. Thank you.
Great, thanks. So Jeff, can you also address this question very briefly again? I'm sorry about that.
No, I think Frank covered it very well. I mean, I think the issue is making sure that we don't continue to work in silos. So when I mentioned the 6 building blocks, we like to think of it more as a circle with people in the center, reflecting the dynamic interaction of the different parts of a health system with all of the people, not just the patients, not just who show up sick. And the linkage between health and social care is extremely important during the pandemic, and it's extremely important all the time. I'll just make one final comment, what Frank said about, the face masks. Acquiring face masks that are either disposable every day or that need washing in warm water and then can only be washed 30 times is a great challenge, not just for the homeless, but for many marginalized populations and many people who are working, but simply, not earning very much money. And I think, governments need to work much harder to provide face masks, to provide gel during the pandemic, to interact with the population, to make sure those social services are pinpointing, where we need to do more so that the health system isn't just receiving sick people, whether it's with COVID or anything else, but instead, preventing more generally. Thank you.
Thank you. Alina?
Thanks, Boris. I mean, I think coming back to Commissioner Kyriakides' comment, I think what her comment is a call to solidarity and collective action. And it reinforces her point about health as a basic human right, which seems so self-evident, but often when we start to speak about access to services, the conversation very quickly turns towards discussions about deservingness and scarce resources. So I think what COVID-19 brings us is, one of the things is actually perspective. And we suddenly see that a lot of those arguments that, they effectively create exclusions, they just kind of fall away and we see that they don't make sense. And so, I mean, we've seen examples in the context of undocumented people of states that have actually taken steps to, as I mentioned, Ireland extend social protections to undocumented people. In the case of Portugal, to grant at least temporary status so people can more easily access services. And I think what's really important is the justification for these measures doesn't end when the pandemic ends. And so we all, policymakers, NGOs, need to seize this moment and the perspective we have now to really press for systemic, sustainable changes that permanently fill the gaps in our social and health systems.
Thank you. And Julie, you will have the final word on this panel. And again, thank you so much for joining us. I didn't mention that, Julie is joining us from the other side of the Atlantic. So she's in a different time zone altogether. But in a sense, this is, one of the benefits of having to use webinars and online technologies. We have the opportunity to be joined by a lot of people. So what would you be your final word on the type of political action that is called for in order to ensure this sort of people-centeredness for healthcare delivery systems?
First of all, I feel a little bit humble because the other panelists have so much more frontline experience than do I. But I think that the concept that we're struggling with here is truly a universal construct. There are people everywhere in the world that are being left behind in the response to this pandemic. And if there was ever a poster child for universal health, this is it, where we really need to see this as a clarion call to engage in the global efforts to assure that all people have access to basic health services at an affordable manner, but also that the quality of those services meet the standards that we have come to expect in a more developed world. I think one of the great advantages of this coalition of people focused on this particular set of vulnerable people is that we can set a standard of care. And that standard of care may seem local in its inception, but it could have universal application. Just as you were saying about inexpensive masks or washable masks, etc., there are solutions here that are practical, affordable, and will save lives. And we have the opportunity to catalyze the dissemination of that effort into the far corners of the world. So I feel really privileged to participate in this conversation, and I look forward to hoping to try and support the catalysis of more impact and more distribution as we go forward. Thank you.
Thank you, Julie. So thank you all for having participated in this second panel. Thank you, Alina, Freek, and Jeff. We will now quickly turn to our Goodwill Ambassador, Dr. Andriukaitis, a former EU Commissioner for Health and Food Safety. So bye-bye, everybody from the panel, and welcome, Dr. Andriukaitis.
Hello, Boris, and thank you very much indeed inviting me. Now I can take my clock because I know that I have only 7 minutes.
This is good practice. I should use it. I should use it.
Let's start, okay, from the beginning.
Okay.
May I quote out my first sentence, because in 2019, on 23rd of September, may I remind to all of us, all leaders around the world, they signed agreement about universal health coverage. And may I quote, the right of every human being, without distinction of any kind, to the enjoyment of the highest attainable standard of physical and mental health. Indeed, it would have been difficult to imagine how within just 6 months, a viral pandemic would emerge and stretch out our health, social, and economic systems in such unprecedented way. But please keep in mind, such promise of all our world leaders, including all 27 European Union member states leaders, is valid. We need to do more. Okay, current COVID-19 pandemic screams out about gaps in national health care and cure systems and lack of European and global solidarity in tackling common enemy in every single mass communication measure, and it's taken by every politician. Meanwhile, problems of homeless people or people in poverty are largely ignored and taken by policymakers only, so-called on a convenient occasion. We cannot deny it is essential to address global pandemics, also the growing epidemic of chronic non-communicable diseases. At the same time, do we really have the right to leave behind those most vulnerable, whose problems are not so loudly publicized by politicians and the media, but rather quietly experienced by homeless people or people in poverty on a daily basis? And now is a question, and our webinar is very timely to raise those questions. Please look at this slide about damages. Can you imagine those data is from ILO, FAO, and others, including WHO. Tens of millions of people are at risk of falling into extreme poverty now. The number of undernourished people, currently estimated at nearly 690 million, increased by up to 132 million by the end of the year. And nearly half of the world's 3.3 billion global workforce are at risk of lost livelihood. It means that we will see much more homeless people. much more people and vulnerable people. It's absolutely crystal clear that now we can, unite our forces and raise those questions very loudly. As please, next slide. As Sir Winston Churchill so rightly said, never let a good crisis go to waste. It is our capacity and obligation as our society to take care. Health is wealth. Public health and growth of economies are just two sides of the same coin. There is no either or. And and when the dust will settle down over COVID-19, it will be our obligation to remind politicians that health cannot be taken on a convenient occasion only. It is an everyday business. And as you know, it is complex and profound effects on our societies. The coronavirus pandemic has underscored the need of comprehensive and people-centered approaches to health and support services that leave no one behind, in accordance with the principles of universal health coverage. Moreover, the pandemic and in some cases governmental responses to it have starkly exposed how many marginalized people in Europe are already living outside the health and social care system. Just in panelists, all panelists mentioned about housing problems, about masks, about because it's everyday reality. Not leaving this group behind means first ensuring that all services, support measures and information equitably reach, benefit and empower everyone without discrimination and with due regard to the particular challenges among marginalized groups. Today's report by the Nobody Left Outside initiative explores these issues with particular focus on pandemic responses, recovery, and preparedness. However, the principle applies across all health and support services, not forgetting the disproportionate burden of chronic diseases and mental health conditions, as well as infectious disease among marginalized groups. So when we see homeless people and other groups on the margins of society, on the streets, in subways, and in public squares, please remember that our promise to leave no one behind is about them, and it is about us. It is our litmus test for us, for our humanity and for our confidence. Now is real time to take into account prevention is better than cure. Like never, it is important now to see how can we translate prevention is better than cure into reality. And of course, health in all policies. Today, it's evidence, especially looking at marginalized groups, because when we are speaking health in all policies, what are we doing to strengthening our efforts addressing issues of marginalized groups? And of course, leaving no one behind approaches. And now is a real time to take into account one word: solidarity. Solidarity is a key in solving all issues related to nobody left outside and nobody left behind. And may I ask? Okay, let's go. Let's go to my second slide, speaking about what about Europe. EU is having a moment on health. Europeans express their, strong and unequivocal wish to the EU takes more active role implementing SDGs, implementing, European pillar of social rights, and of course also, developing actions related to SDGs. Please look, those 3 billion targets for 2020-21. Now we have 2020. It's up to us to understand that those targets are reality, especially looking at those hundreds of thousands of people who are just in the very difficult situation. And I may, let's go to the next slide. Once again, okay, now what is about European Union? Now it's a real time also to say that we have good opportunity to raise European Health Union questions high on the political agenda. We need to strengthen our instruments at European Commission level, at European Parliament level, empowering much more NGOs, empowering much more communities, but we need to change treaties. We need to think about possibilities to develop new, instruments to keeping in mind the situation to build European Health Union. Thanks, Boris. 7 minutes is over.
Thank you, Dr. Andriukaitis. Many thanks for this intervention. So I'm afraid we're already, beyond our allocated time. I'm happy that our friends at the European Health Forum Gastein subscribe to a longer time slot with Zoom, and that we're not disconnected. So we don't have time for questions. So I will close the webinar right now. So thank you very much for having joined us, and I look forward to continuing your leadership and goodwill ambassadorship for the Nobody Left Outside Coalition. Many thanks for your support. So I will close the call now. I want to first thank the European Health Forum Gastein for organizing this webinar, and I also want to thank our friends at Interrel who helped us make it happen. I hope you found our discussion today enlightening. We had many voices, and again, I apologize for having gone a bit over time, but I would think that you understand the reason why, given the richness of the interventions that we were able to gather with us and for you today. So I would just say that the communities represented by the Nobody Left Outside Coalition are often referred to as being hard to reach. With this initiative, we wanted to turn this around and show that it is rather our health services that are hard to reach and not the people. So putting the people at the center of our health system is really the way forward, and not leaving anyone outside is clearly a responsibility of our health systems, but also a way forward to achieving our public health objectives. So with that being said, make sure to visit our point of view photo exhibition. It's really, really great. And you can also hear more from our speakers today through and others through the podcast series that we have launched this week during NLO week. They're available through Paul Adamson's encompass-.com website. That's encompass-.com. And you can join the conversation on social media using the hashtag NLO week and the handle Nobody Left Outside. So thank you again for joining us today. Bye-bye and have a nice weekend. Thank you.